Dinesh Kumar, Blend Health Technologies.
Awesome. Well, thank you, Udi, and thanks everyone for staying here. It's from hypersensitivity to hypertension. Right, so my name is Dinesh Kumar, CEO of Blend Health, and you can see that, okay, well, Columbia got replaced by InnovatorMD, but we are a Columbia University spin-out, working on a cuffless blood pressure monitor for upper arm. So we are the only one who are doing it on upper arm, and also getting clinical quality results. So I think with everyone being a doctor in this room, I don't really have to spend too much time on complications of hypertension, afterwards being hypertensive, and just cost and just even human cost in terms of your deaths and complications, basically related to from brain to kidney. So it's a obviously huge problem. And one of the main challenges that is generally acknowledged is that blood pressure, it basically continues to change throughout the day. It's variable, plus minus 15-20% even. And we reduce it to, we measure it occasionally. One even gets diagnosed when they go to see a doctor after like once a year or even less. And only after diagnosis does one even go and buy an ambulatory or buy a home-based blood pressure monitor. And even so, they don't measure it daily. So as a result, the medications are inaccurate and they are not refined. It takes a long time to refine. And by the time, even so many times, many patients discovered that they were hypertensive only after there has been a major incident like their kidney failure or some sort of neurological issues. Right? So we want to, and there's currently some solutions, right? So like ambulatory blood pressure monitors, and even 5 to 10 million kids a year actually take this home wear for 24 hours that squeezes their arm every half an hour to take a blood pressure reading to make sure that it's not white coat syndrome. And likewise, they also want to look at masked hypertension when they see that their symptoms. Hypertension is both a cause and a symptom of problems. So what you want to do is, what we are doing is make a continuous, and by continuous mean, at least in ambulatory setting, every 15 to 30 minutes, reading that one can wear throughout the day without squeezing the arm and passively, without the user even knowing that's being measured. So this is the form factor currently. So we have just built our MVP. It goes on the upper arm, and it's a light-based technology, so which is PPG. And there are some products that have tried to do it on the wrist or on the ring. Now, why upper arm? Again, that's where a lot of normative data is. It's at heart level. And second is the hydrostatic pressure, right? So if it is on the wrist, we see that much blood column is really adding up on the wrist, and it changes from up to 50 to 60 millimeter of mercury when you move your arms around. So we actually can do that using biomechanical to reduce it even on the wrist to very tight band, but wrist is still not the right location to measure. Then you are depending on the spot check alone. So we put our sensors directly on the brachial, and underlying technology. So I'll go into the next slide, but the principle behind that is multi-wavelength sensing, which means that we look at how blood travels from arteries into capillaries through arterioles. And with high blood pressure, it travels faster, and with lower blood pressure, it travels slower. And that's really the underlying principle. So it's a very lightweight device. It looks, kind of like, to me at least, it looks bigger than it is, but all it does is, and battery is meant to last for a week. So you can actually wear it for even a week. And it only collects data and transmits data over to an app, which is connected to our cloud, which connects to a physician desktop app. And we have interviewed cardiologists, nephrologists, and internists to basically build dashboards for them. So that's the underlying principle you see on the top left, really, infrared and red wavelengths, and they go as deep as 1 centimeter. They go all the way up to artery. So it's a reflectance-based mechanism, and when we look at green and blue, they are very superficial. They go barely a millimeter. So many devices, basically, when they're using green, like the Apple Watch, it's looking at very superficial level with pulse wave, and that's how it looks at heart rate. So we look at the signal all the way from arteries and also link it only to capillaries. And based on the these signal differential, the time difference between them, we estimate the blood pressure. And further, we connect based on inertial sensing using IMUs and accelerometers. We correct for hydrostatic errors so that we can estimate the pose, and we correct for that so that we get final accurate blood pressure. So we have licensed a few patents, and there have been a few articles on this as well. And we also filed joint IP with Columbia. So yeah, I think market, these numbers really underestimated a lot, but we think of ambulatory blood pressure monitor as our initial beachhead, and we have hypertensive and even concierge clinics who are we have aligned with to really look at potential for RPM based, remote patient monitoring based business model. So these ambulatory blood pressure monitors currently sell in the range of $3,000. So they have a big battery pack with cables going and squeezing every half an hour. Our compared to, let's say, $30, $40, the Walgreens one that you get. So the pricing is $400 one time and $40, which is 1/3 of monthly RPM CPT reimbursement. So that our lifetime value is somewhat comparable to, but that's the value that we add also. So with the beachhead being at concierge and practices, next is really expanding into a cardiovascular risk prediction. Because blood pressure and blood pressure variability is a big factor in determining, for example, the cardiovascular risk. And what that also means is, for example, even possibility of a stroke and possibility of cardiac arrest. Be able to predict that in advance and be able to potentially avoid it. But in long term, our vision is really getting to wellness space as well, so which is consumer, but we see ourselves as medical device first. So we'll be going with FDA clearance. Submission is probably by end of this year and in market next year. So in terms of competition, I think that's a lot of people see, right? So that there is consumer devices that go on the wrist. There are some devices that are that do trending blood pressure, but we see ourselves as up there, and based on publicly available data, we really are there. So revenue model, the reimbursement, reimbursements really support this model, and we expect to get to revenues next year. So at Columbia, we have been collecting data over the last 4 years under different IRBs and with our R&D prototype. Now we have our MVP, and we'll start doing clinical validation in February, requesting FDA pre-sub at the same time. So we expect to meet with FDA in April, around April type time frame, and within 6 months of that, expect to submit our FDA 510K potentially. So our regulatory analysis says that will be most likely a 510K, and in basically a small chance that it could be a de novo, but the clinical validation will be very similar. Because there's no other device that's currently cleared for this exact indication, so it will be a combination of 510K. So in terms of team, well, you see the handsome guy on the left side, that's me. So they always put my picture first up. Sam is professor at Columbia University of Biomedical Engineering. So he had been working on this project for several years before we licensed it a year and a half ago. Ram has again 20 years of experience in biomedical engineering and medical device innovation. And likewise, right, so everyone on team has significant experience in what they do. And likewise supported by product development, software and hardware companies. And similarly, right, so you might or might not know some of these physicians again from different places like UCL Wine and Cleveland Clinic. And currently we are just closing our pre-seed round. So we have already met our milestone for that, which is MVP, and starting to raise our next round of $2 million. Which is seed round, and that basically lasts us a year and support FDA submission. So that is, thank you.
Right. Thank you. Any questions for Dinesh?
What is the accuracy of the device? Like you mentioned it, like
Yep.
you said it's very close to the real numbers.
Yes.
How far are you? Like 1%, 2%, 5%?
So the standard for cuff-based devices is it asks for mean accuracy of ±5 millimeters and ±10 on standard deviation, +8 on standard deviation. So in our cross validation, we are within ±1 and standard deviation is ±1. So we, again, this is early data. So So real patients will probably challenge that a little bit, and we may need to refine too. But so far it's basically way tighter than commercialized cuff-based devices.
I'm assuming you'll get those with the prototyping testing, but how do things like obesity, low flow states, I mean, obviously those are more like hospital inpatient, but how do those things, which could be the big thing you're looking for people at home,
Yep.
any idea about how those things might be affecting the results?
So based on body type, etc., right? So one is skin tone, obviously. So for that we need to, so that just basically determines the gain, right? How much current do we need to pump into LED? So the other is we do one-time calibration. That's one time because the PPD looks at only the variability. So we need to have a baseline, and that baseline basically addresses, so it's individualized to every person, and it's a one-time setup for like 15 minutes. And there are basically reimbursement codes for that setup as well. So beyond that, we haven't had need for recalibration. We have done longitudinal studies on people as well. So age-related arterial stiffness changes will challenge that, but that means that periodic calibration may be as far away as a year or two.
Now, are you collecting also, it's like, I really love this idea, I'm an anesthesiologist, so, do you guys collect the actual waveform data, or?
Yes.
Okay,
Yep.
and so you guys can actually look for biomarkers and specific things to make it even more precise?
Yeah,
after the
absolutely.
fact.
So we look at, so from waveform data, right? First things to clean it up, then we look at transit time. That's again, we look at 20 different parameters, and then other 3 to basically pulse wave analysis.
Yes, diastolic transit time is supposed to be doing the best.
That's the number one always in our models.
Okay,
And it's not unlike, let's say, one side to another. It is basically inside out. So it's almost like pseudo transit time. So that's why we don't need 2 sensors, along the arm, or one at heart and one at.
excellent.
Okay, thank you very much.